Hello out there. My name is Margaret Grotle, and it's a pleasure for me and an honor to present Professor Nadine Foster. She is the National Institute for Health Research Senior Investigator in UK, and she's the director of the Clinical Trial Unit at Keele University, and she is one of our leading experts in musculoskeletal pain research in the primary care, and in particular in the lower back pain field. She is also the first author of the second Lancet paper, in which the focus was the treatment and the challenges in low back pain in primary care. And I think this presentation is to take us a step further from that Lancet paper.
Thank you very much. And thank you for inviting me, and it's great to see this seminar and webinar happening. And for those of you who are joining us via the internet, I can't see you, but thank you for joining us. So I'm going to focus on some of the key messages that we developed as part of our 31 strong Lancet series team that we put together as part of our series, our second paper, where we tried to look at the evidence for prevention and treatment of low back pain, and then think ahead positively, because of course a lot of what we're talking about so far, it can be viewed as a rather negative message. You know, we've been working in this field as clinicians and researchers and patient groups, and you know, back pain disability is still rising. So we were wanting to come forward with some solutions, even if those solutions weren't yet as strongly evidence-based as we would like. So I want to share those positive messages with you. So I'm going to just take you through some of the key points of our second Lancet paper, and some of these messages will overlap with the messages you've heard from Rochelle, but I always think a little bit of overlap is helpful, so hopefully there won't be too much overlap. And Rochelle has already very nicely described how much of modern back pain care is ineffective. And I've put a bit of a caveat around that, or based on insufficient evidence, or is harmful. Let's take a closer look. So in our series, we reviewed the evidence for the key area of prevention of back pain and the key area of treatment of back pain. And this one slide essentially summarizes the very weak evidence base to date in the field of prevention. Drawing on 2 high-quality systematic reviews, in adults, only 21 randomized trials internationally, in children, only 11 randomized trials internationally, a real dearth of evidence in this field. And what I've just tried to do to cut quickly to the chase is highlighted in green some of the key take-home evidence of things that might be effective. And so far, despite the sort of push for insoles, back supports, new mattresses, you name it, workplace, ergonomic furniture, changes in redesign in the way that you work, and so on and so forth, the best evidence that we have so far, albeit not yet of good quality, is that exercise and education is the only effective thing in adults. There's very little evidence in children, but of that evidence, there's some suggestion, but very low quality evidence, that ergonomic school furniture might be helpful. But there's a clear message here as we move forward that we need to be doing so much more work in the prevention space. Even if we take forward this message that exercise, either alone or combined with education, halves the risk of back pain, when you look more carefully at those 21 trials, you find some very interesting things. The vast majority are focused on secondary prevention of back pain rather than primary prevention, or even primary prevention of back pain recurrences. So the field is still very much about secondary prevention. And when you look at the populations in those trials, you'll find that they're rather unusual patient populations. They're mostly done in military populations. They're mostly done in healthcare practitioner populations, such as nurses. So the transferability of these findings to the general community-based populations that we want to generalize these findings to is highly questionable. Also, the interventions in some of these prevention studies are extremely, I guess, unusual, depending on the setting, of course, but certainly from my perspective in the UK, our national health system wouldn't be offering, for example, 20 one-hour sessions to prevent back pain. We hardly offer 4 or 5 sessions to people to treat back pain. So clearly some of these interventions are not going to be the kinds of interventions that we can offer broadly at scale that's needed. So a lot of work yet to do in prevention. When we move to treatment, and again, I'm just going to try to be very quick about these messages because it's all in the paper, highlighting in green where we think we have reasonably good evidence of something that should be offered as a first-line treatment for non-specific low back pain. When we think about education and self-care, then yes, there's a positive message around advice to stay active in education, and all the guidelines are recommending that we do that as first care and that we use it routinely. But when we think about some of the other non-pharmacological therapies, well, that's where the evidence really starts to be a bit disappointing. Exercise therapy and cognitive behavioral therapy in green. Spinal manual therapy or manipulation is a second-line treatment, as is many of the other non-pharmacological interventions that we offer back pain. Again, what we're seeing here in some of these interventions is insufficient evidence. We move to the pharmacological therapies, the medications that are commonly used, and we don't see any green on this slide. Increasingly, as we do these trials of the common medications for back pain, that's pushing us really to then not recommend most of these medications, most recently paracetamol, but also increasingly, I guess, questions around muscle relaxants with research calls for more evidence and a great deal of warning, as Rochelle already mentioned, about the use of opioids with back pain and that shift from weak opioids that are short-acting to longer-term use of opioids and the harm that's associated with that. And the last slide really summarising these, the summary of best practice. We looked across the literature at invasive treatments. And again, no green on this slide. So nothing here to be offered routinely for back pain patients. And I know this is a hard message because many of us are trained as clinicians and we've gone into the field of being interested in back pain because we want to help patients. A lot of clinicians are working in this space, and these are tricky messages to share. But I think, to try and be positive about some of these messages, we're seeing for the first time internationally researchers and research funders and clinicians working together to do things like, for example, the trials in the Netherlands that meant that the recent evidence on things like radio frequency denervation were able to be done really quite quickly and deliver that evidence base. In the UK, we're seeing research funders really pick up some of these more invasive treatments and say, okay, now let's really look carefully at the evidence. Let's deliver that evidence in order to better inform practice. Because so much in this space, as you can see on this slide, is based on insufficient evidence currently. In the UK, for spinal fusion, our NICE guidelines suggest that spinal fusion for non-radicular, non-specific low back pain should only be done in the context of a randomized trial. So those shifts are happening, and I think those shifts are a positive thing. So the key messages really from our paper in the Lancet series is the only known effective intervention for secondary prevention is exercise, either alone or combined with education, but so much more work is needed to focus on prevention. That the first choice for treatment should be non-pharmacological, and only if patients don't respond to non-pharmacological care should we be then thinking of some of the pharmacological treatments that we have to offer. Universally, the guidelines are recommending self-management, physical and psychological therapies. And there's some disagreement in guidelines, but some of them do suggest some forms of complementary or alternative medicine. But what's really clear as we move through guideline from different countries over the years is that they're placing much less emphasis on the pharmacological, the invasive and the surgical treatments. And they're advising against some of these electrical physical modalities that were traditionally part of the core toolbox for back pain. They're all suggesting that the routine use of imaging and investigations is not recommended. So the second key message, I guess, in our paper in the Lancet is that despite this evidence base, despite us, seeing reasonably consistent messages in most international guidelines for back pain, that non-evidence-based practice is apparent across all countries and all income settings. Rochelle has already highlighted in good detail some of these key examples. We've summarized them in this paper, and I was just going to highlight a couple of slides that highlight these high income settings and the pervasive nature of poor care. So for example, despite advice being in green, as I said earlier, and saying, yes, advice and education, reassurance that back pain is not a serious disease that needs a medical solution. Even in Australia, a high income country, only 21% of consultations with a GP incorporate that type of advice. And that despite all guidelines not recommending routine imaging, you can see here that in countries like Italy, 56% of emergency department patients being imaged, 42% being given an opioid. So poor care is pervasive in our high income country settings. But one of the really interesting developments that we went through as a group of authors on the Lancet series is that we were kind of hoping that what we might be able to say is, look what's happening in these high income countries, and let's make sure that low and middle income countries learn from this so that they don't also develop this poor value care pattern. And what was really clear already when we looked around the world for studies that describe current clinical practice is that this poor value healthcare is already well entrenched in these low and middle income country settings as well. Here we see in India, 46% of physiotherapists advising patients to rest. In China, non-specific low back pain being the most common reason for an MRI scan. So what we really need to do is learn from these studies, learn from this evidence practice chasm, as we call it. We've certainly made key mistakes over the last several decades. And those key mistakes have been thinking errors in non-surgical healthcare, and to pick just a few, that over-reliance on medication as the first line treatment, and the offer of other passive treatments, the increased use of non-surgical intervention procedures. So in the UK, for example, now that the message seems to be more well accepted that we shouldn't be injecting people for non-specific back pain, and we certainly need to be thinking more carefully about doing things like spinal fusion. What we've also then seen, of course, is a transfer to other interventional procedures, such as the radiofrequency denervation numbers are going up in the UK. Because we haven't had a clear message yet about whether or not clinicians should be using that. So clinicians shift, don't they, from some non-evidence-based or questionable care to other care in the meantime. So that's why we really do need to get evidence behind some of these other interventions. Rochelle's already mentioned research waste. That was another really apparent thing as we were developing this series. We have over 2,000 trials of treatment for low back pain, and only 21 prevention trials in adults. So there's a clear mismatch between the research that we need to do in order to ensure that we address the public health concern that is back pain. And that shift's going to have to be about changing research funders' perspectives of the kind of research that they need to be funding in this space. We've also made clear errors in surgical management. And when you go right back in time to why on earth we ever started fusing people's spines, of course, the key error there is thinking that abnormal movement was the cause of back pain, and that focusing on stopping that movement through fusion surgery was the solution. We've also seen, of course, historically, a reluctance or a belief that we cannot research surgery. And it's unethical, for example, to randomize someone to surgery or non-surgery in a trial. And again, a really positive development internationally is that we're now seeing those trials being done. They're challenging, of course, but they can be done. We're seeing it in, for example, shoulder disorders, where these trials are now having sham comparisons as well. So the evidence base will grow, but we absolutely need to deliver on clinical and cost effectiveness evidence for these more invasive interventions. And if we think beyond, these errors of non-surgical and surgical management, I guess more broadly we'd say that a key error has been seeing low back pain through solely a medical lens, and the need to consider that broader model of understanding of back pain that Rochelle mentioned in her slides. Much of our back pain paper, the second paper in the Lancet series, focused on trying to identify emerging, promising, or indeed effective interventions from around the world that might help us move forward and be more positive about the messages. So what could we be suggesting that we should be doing? And what does that evidence look like, and how do we move forward? So I'm going to spend most of the rest of the time really focusing on highlighting some of these promising new directions. And I'm going to be absolutely honest, some of these are not based on strong evidence. And what we've tried to do is identify where we feel it's emerging evidence, it's promising evidence, or it's effective evidence, based largely on whether it was designed as an evaluation that is sort of a robust evaluation in terms of its research design, whether it was confined to one study in one country, whether it's been replicated, and so on. So we're trying to give a sense of the evidence base around these suggestions. But I'm going to summarize them according to the public health developments, then look at some examples from changing social systems, in particular some of the occupational health interventions, and then finally consider some of the new developments in healthcare. So again, let's take a closer look. The first is public health and sociocultural solutions. And of course, given the need to reduce back pain disability at societal level, public health approaches offer a very sensible solution, even though, as we heard earlier, there's a real research gap here, real need to do more work in this space. Multiple guidelines tell us that low back pain is most often best managed with minimal medical intervention, reassurance, advice to stay active, to keep at work. But we already know, as highlighted previously, this mismatch between that message and the general public's beliefs about back pain, who often believe that rest or protection of the back is needed, along with comprehensive medical investigation and treatment. And of course, a really nice example of this that we highlighted in the Lancet paper was this study of back pain beliefs among Aboriginal Australians, a population that had been previously shown to have protective cultural beliefs. The back pain's not really a health issue at all. And the study showed that this group then proceeded to have biomedical beliefs about the cause of back pain, and they attributed that to their interactions with healthcare professionals and the results of spinal imaging. And that example highlights that sociocultural change in terms of the public's beliefs and responses to back pain are needed, along with adjustments of society's excessive reliance on biomedical solutions. So public health interventions aim to change the public's low back pain beliefs and behaviours. In this series, we highlighted the 4 currently published evaluations of mass media campaigns in the field of back pain from Australia, Scotland, Canada, and Norway. This is a busy slide. I don't expect you to read the detail, but just to get the sense of the differences perhaps in some of these mass media campaigns. Of course, the first thing to notice is they're all from high-income countries. And a second thing to notice now as the years pass is that these evaluations now are really quite old. And there's some ongoing evaluations, as we heard, in Canada and Australia. But I guess what we wanted to do in the series is just again highlight the potential of using mass media to really help shift the public's beliefs and behaviours. The joy of these mass media interventions is they hit all of us, not just patients, but also healthcare professionals, policymakers, payers are all exposed to these messages. Moving on really to think about the key differences between these in terms of results. I guess my take of looking across these results is that they all showed positive shifts in beliefs, but it was really only the Australian campaign that also appeared to show changes in behaviour through things like there in the bottom left, reduction in the number of claims, medical payments for claims for back pain, and the rates of days compensated. And of course, in hindsight and reflecting on the differences, this Australian campaign had a very much larger budget and used primetime television commercials with well-known sports personalities. And critically important at the time was the supportive laws and policies in place that supported the messages in that campaign, particularly with respect to, for example, employers needing to provide work modifications for folks with back pain in their employment. So again, really highlighting the potential for moving this now forward. These were based mostly on TV and radio mass media, but of course now in this new millennia, we have many more ways of thinking about how we might have more targeted messaging. I bought this jacket last year, and now that I bought this jacket from this online store, every time I go on the internet, I get flashes, on the right-hand side about other jackets I might like to buy. We must be able to harness that personalized marketing in these media to be able to do something more positive in the field of back pain. So public health and sociocultural solutions are something that we'd like to see more of. And again, for those of you particularly watching on the internet to this series of talks, we couldn't find any published evaluations of this type of intervention from low and middle income countries. But nevertheless, we feel this direction is promising, and we'd like to see countries consider replication of the Australian campaign using newer social media, personalized marketing approaches. But the key message, I guess, from across these 4 examples is that we need to be focusing not just on beliefs of the target audience, but behaviors, and consider ways to add back health information and key messages to other public health initiatives. A second key area of potential solutions is in the area of social and work systems. So thinking about patients getting back to work, thinking about changing the compensation and benefit systems. Evidence shows that there's substantial differences in the prevalence of back pain. Rochelle mentioned this, but just to come back to that, because the differences are really very stark. So substantial differences in low back pain related claims for disability benefits. And in this study, the USA was 60 times higher than Japan, 60 times higher in terms of back pain related claims. And these are both high income settings. In a middle income setting in Brazil, claims in some states are 5 to 6 times higher than in others. And this is all to do with the social system and the compensation system for back pain. We know from several studies that there are real effects of different compensation systems on low back pain, and that changing from fault-based systems to no fault-based systems that provides payment to patients for pain and suffering to a no-fault system without these types of payments, we see fewer claims and shorter times to claim closure. And the evidence there is coming from countries such as Australia, Canada, and Brazil. So again, we can see these positive changes that we can make, but these are system solutions. Changing these compensation systems aligns with the recommendations from the Organization for Economic Cooperation and Development that advocates changing from a passive benefit system that promotes into systems that promote employment, where workers and employers are actually stimulated in ensuring that work accommodations are possible, and the healthcare system is also stimulated to support the patient in return to work. We drew on this example from the Netherlands team that compared compensation policies and their effects in 6 different countries. We've seen the difference here in the top line in blue, which is the context in Germany, and the bottom line in, I think it's about a purple color in the Netherlands. The graph shows that there's much shorter sick leave duration in the Netherlands in comparison to all of the other countries, the USA, Israel, Sweden, Denmark, and Germany. And those differences are largely explained by more work interventions encouraged in the Dutch compensation system. So we absolutely have to do more in terms of changing compensation systems and essentially payments for people being off work with back pain. This further example, again from the Netherlands, which we badged as emerging evidence because of the designs of these studies, highlighted the effect of reforming the laws in the Netherlands over a 5-year period. Again, quite an old study from 2002 to 2005. And these new laws meant that employers needed to do things differently for their sick employees with back pain over a 2-year period. They had to make a return to work plan that was agreed by all stakeholders. They delayed medical assessments over a period of 2 years to give folks the chance to return to work and to work out what they needed to support them to return to work. And they had a medical assessment only after 2 years to decide on next steps. And this graph highlights the difference that those laws made over that 5-year period from 2002 to 2007. These bars represent the total days of sick leave and the number of workers on sick leave, and you can see those reducing. The team also estimated the costs of this and showed a lower total cost of back pain over that 5-year period. The reason why this was judged as emerging is, of course, the control comparison limitation. There is a lack of control in these sorts of studies. But this is an example of a multi-system solution that other countries could consider emulating by getting all of those stakeholders together to change the system for back pain. It highlights the power of social policy change that encourages more work interventions supported by less strict compensation policies for disability benefits. And I'm going to wrap up by thinking about our healthcare solutions that we identified. And again, some of these have stronger evidence base than others. But the 3 key areas we looked at were, firstly, focused implementation of best practice. Secondly, as came up in some of the earlier discussion points, reforming the education and training of healthcare professionals. And lastly, changing healthcare systems and pathways for back pain. So if we take a look at the first of these, which of course is implementation of best practice, we know that despite the multiple clinical guidelines that we have with broadly similar recommendations, this evidence practice gap or chasm depicted here on this slide is pervasive. And yes, we do have innovators and early adopters, like in all fields, but they're in the minority. And we need to do much more to implement what we already know is best practice. And again, to take a positive message for this, there's a tremendous opportunity to improve things by implementing what we already know and reducing the costs of back pain by more effectively implementing the best evidence that we have. We know that just producing guidelines is not enough. There's lots of nice evidence now that we need to do more than develop guidelines in order to change clinical practice. And again, there are promising solutions in this space. We drew on a couple of examples in the paper. Again, these are quite old, but we tend to forget and we move on. A nice example from the USA, where the simple introduction of a special X-ray requisition form for emergency room doctors led to a reduction of about 37% in the requests for lumbar spine X-rays. And the nice and simple nature of that was, from tomorrow onwards, they needed to use a different form to request that X-ray, and no one would be X-rayed unless that form was used. And that form only allowed 3 evidence-based criteria for requesting that X-ray. So a simple intervention that can reduce unnecessary imaging. In the UK, a short educational standardized messaging system that was attached to all MRI reports that GPs requested, again showing a reduction of about 23% in lumbar spine MRI requests. These are relatively simple interventions, but that can reduce low-value healthcare. We've also seen a couple of nice systematic reviews published recently, pulling together the evidence about implementation for back pain. And the nice thing about these 2 reviews, unlike sometimes, but these 2 reviews have very similar conclusions. Educational interventions on their own, so coming to conferences, listening to webinars, these things on their own aren't enough to change practice. And we previously thought that if we threw more into an implementation package, if we made it more complex with multifactorial components, that would increase its effectiveness. These systematic reviews highlight that that's not the case. They show that even multifaceted implementation strategies do not significantly improve professional behaviour. Rather, what it appears is that implementation efforts need regular repetition, or they need to be ongoing in nature to effectively change practice for back pain. And of course, that's much like those two examples on the previous slide. Changing the system that meant from here on in, this had to be done in this way, or giving reminder and repeated messaging over time. Those are the things that appear to be more effective in changing clinical practice for the better. There are some key issues in this implementation space, and we certainly have not got all the solutions that we need yet. We need to work out how to de-implement unhelpful practices. We're not sure yet, but we think that might not be the same as the strategies that will be effective to implement new practices. We also need to do much more around the cost effectiveness of implementation strategies. Of the research that we reviewed in these Lancet papers, we could find only 3 randomized control trials to date of an implementation intervention to change practice for back pain that had an associated health economic analysis. So currently we really don't know whether some of the efforts that have been, that are thought of and that are being used to change practice are actually worth the money of those efforts. So that again is something that we need to listen to as a research, academic and clinical community and help make sure that we deliver that evidence. We do need to make tougher policy decisions to reduce the unhelpful influence of industry. What was so clear to us writing these papers is that in many countries, we have this bizarre situation where we reimburse how much care a patient gets rather than the quality of that care. So implementation efforts are going to have to tackle reimbursement and payment models for the healthcare system. Another key solution was to reform healthcare practitioner education and training. We know what some of the key problems are in this space, the way in which we're all educated separately in our disciplines with very little understanding or sometimes respect for each other's roles, the limited content, particularly about musculoskeletal disorders and back pain, particularly in the medical curriculum, the continued focus on a biomedical diagnostic model that directly links imaging findings with symptoms and treatments, which of course has failed to reduce low back pain disability and costs. So we know what the contributors are to this difficulty, and we need to try to overcome essentially the optimism bias that we all tend to have as clinicians, that we think that the treatment we're offering is perhaps more effective than it really is at a sort of average level across our patient population. We highlighted some key examples from around the world that are doing things differently, acknowledging completely that the evidence for some of these in terms of what difference does it make is not yet available. But for example, in Denmark, the integrated education of medical doctors and chiropractors has been ongoing now for some years. Very different model than other countries. Is that making an impact? Is it changing how back pain is managed for the better? We're not sure. We need some better data. And a promising training program in Sweden, for example, again, quite an old paper here, where training physiotherapists led to greater behavioral treatment orientations in back pain and weaker biomedical treatment orientations. So it is possible to change healthcare practitioners' beliefs and practices, but again, a space that we need to do more in and a space that we need more data on. And the final key solution that we highlighted in the second Lancet paper, I guess, is the sort of ultimate challenge, which is to change the clinical care model for back pain, to rethink how we're managing back pain as a clinical pathway, as a clinical model. And the examples we used here are firstly an approach that would make more efficient use of existing limited low back pain healthcare resource in ways that aren't about diagnosis but prognosis, and reforming completely a low back pain clinical pathway so that right from it matters who the patient sees first, right through to specialist spine care we reform these pathways. Given the sheer volume of low back pain patients, we must not and cannot offer intensive and expensive interventions to all. So we need to be doing more about simplifying, standardizing, and increasing the accuracy of healthcare practitioners' assessments and decisions. So taking a sort of systems level approach and thinking, how do we make the best use of our limited healthcare resource? Who can be supported to self-manage? Who really does need more of the invasive or intensive interventions for back pain that we can offer? An example of this was the research from Keele University around stratified care, using simple tools that patients complete themselves that help inform clinicians' decisions about their risk of persistent pain and matching them up to treatment, which changes the pattern of referral. And I guess I just wanted to highlight this because this is about how we use our limited healthcare resource. The Start Back trial, the implementation study that followed, really highlighted the way in which you can shift healthcare practitioner decision-making about onward referral. Very high in patients at low risk of persistent pain in the control arm, but very much more reduced that onward referral in patients that were treated according to the targeted stratified care arm. And yet not disadvantaging the people who are at risk of persistent back pain. They still are treated appropriately. And the cost effectiveness benefits that come from changing the way we manage patients. And the final example that we looked at, we're looking at clinical pathways, so changing the whole clinical pathway for back pain. This is ambitious and difficult work, but there are examples from around the world. By changing the idea that the medical doctor has to be the frontline professional and reforming pathways so that healthcare professionals whose training is more consistent with guideline recommended care are at that first contact initial consultation. We looked back at 2011, found a systematic review then of 4 different pathways. Unfortunately, at that time, there were no data to tell us whether changing pathways was a good thing to do. But since then, we've had some preliminary data, both from Canada and the UK. The Saskatchewan spine pathway, not easy to say, developed in 2011 that involves training for frontline primary care clinicians, a referral to a triage practitioner, mostly in Canada, a physiotherapist, that then decide who's referred on to a spine clinic and who sees a spine surgeon. Now beginning to show reduced MRI scanning and more appropriate referrals to spine surgeons that are the kinds of patients that spine surgeons need and want to see. In the UK, we've completely reformed our national practice for back pain through the agreement of 31 stakeholder groups to develop and implement a national low back and radicular pain pathway. This was updated according to the NICE guidelines in 2017 and is now being regionally implemented through our national back pain clinical network. And from the bottom, it addresses education and primary care and funnels patients in this one single pathway through a triage and treat practitioner, mostly physiotherapists, not medical doctors, in order to make better decisions about who proceeds in the pathway. The limited evidence yet on these changing pathway models is absolutely acknowledged, but I've seen the recent audit of some of the early implementation sites of this pathway, and I can tell you that in the northeast of England, one of the early adopting regions of this new pathway, that patients going into the pathway at the bottom are managed through the pathway such that no one yet, to my knowledge, and according to the data, has been referred to a spine surgeon at the top for non-specific back pain. So these pathway reforms may be really potent ways of changing practice for the better. So we need to learn from the past, we need to acknowledge where we are, live in the present, but we need to be positive as we move forward, that we can use some of these solutions and develop new and different solutions that can better address back pain disability. I won't restate some of these key messages in the interest of time, but they're here on the slides that are summarizing the key messages from the second paper in the Lancet series. about the messages that we know that we should be doing in terms of the promising strategies to reduce disability. That realizing that low back pain is so common that we have to do more in the prevention space, that we have to do more about prevention of disabling recurrences, and that we need to shift our focus in research funding and activity away from what we might call the more expensive search for yet more biomedical solutions to much more public health solutions for back pain, with a much greater focus on integrating healthcare and workplaces. Acknowledging that we haven't done things well, but that we now need to take stock of that across all our disciplines and move forward, in a sort of united way. There's tremendous opportunity to change things if we can work together to achieve this. And at least one of those potent solutions could be healthcare service change, changing the models of care completely for back pain. So I want to leave and stop on a positive message again, that what we've tried to do in this second paper in the Lancet series is draw on international examples that look to be effective, promising, or at least emerging, that we could now begin to think together about how we take forward. They deserve greater attention, but many of them still need rigorous research evaluation. But of course, without this, then 10 years from now, we'll be back here saying the disability and expenditure for back pain has continued to rise. Again, I'd like to acknowledge a whole large team of folks involved in searching for the evidence and writing these papers and developing all of these slides. Thank you to all of you, and thank you to you for listening. Thank you.
Thank you so much, Nadine. It was really nice to listen to you. So I assume that we have some questions from the web and from the audience here. So since we want to really integrate you out there listening to us, then I think we should start with the questions from the web, from the internet. Do we have some?
Yes, we have activities via the web. And someone also tweeted that it was nice to sit in their own office and follow this via the webinar. So that's great. Lars Christian Bråten, he is a PhD student, and he says, in terms of what future research we should focus on, I found your suggestion of focus on prevention tempting, but also confusing. In other medical fields, finding measures for prevention is usually started when we know the cause. To me, research on prevention sounds premature. Do you feel we know enough about all multifactor factors causing back pain to outline new research on prevention? As an early career researcher, I would love to hear your thoughts on this, Nadine.
Well, I'm a pragmatist. I think we need some research that still searches for causes. I certainly wouldn't for a moment think we need to stop all of that research. But my pendulum swings much more in the direction of using what we already know. And we have many quite high quality epidemiological studies and other studies that have identified the multifactorial nature of back pain. I'm sure we don't know all of what we will know in 10 years' time, but we already know a lot. So in my mind, being a pragmatist with a pendulum that swings firmly in the direction of let's try and do something and initiate new research now that will build more evidence for the future, I would definitely encourage new researchers in this field to be picking up this challenge of what we do in the prevention space. Primary prevention is incredibly challenging. That's probably why there's only 21 trials, even in the prevention space at all, most of which are not primary prevention. So it's going to be a tricky road to go down. We know from our adolescent and children researchers in back pain that most back pain starts early in life. and that much of that back pain is not disabling back pain, but it starts early in the life course. So of course, primary prevention is going to be incredibly challenging, but I don't think we should not start. I think we should start, and we should use the information we already know about the multifactorial nature of back pain to develop clear prevention research agendas that mean that in 10 and 15 years' time, we'll be better informed.
Thank you. I think if we have a question from the room here, we would allow that. So could you please hand him the microphone?
Yes, my name is Martin Björklund. I'm from the Umeå University. First of all, thank you very much for a very nice talk and interesting talk. And I have a question regarding the first part of your talk when you talked about the evidence for different treatments and prevention. And taking into account that non-specific low back pain is very multifactorial, as you said, isn't it reasonable to think that some kind of classification, sub-classification, and targeting treatment to that would give better results? Did you have a look on the evidence of these efforts that I know are there?
We did. The Lancet papers went through various, as you can imagine, revisions, and I don't know how many people know, but I can tell everyone that we initially offered the Lancet series, the Lancet editors, a series of 10 papers. We were very ambitious, and they reduced it to 5. So we wrote 5 papers, and then we submitted them, and they reduced them to 3. So as you can imagine in that process, a lot of content and thinking and examples were reduced and reduced. So we did look at the evidence for targeting treatment according to different ways of targeting, diagnostic classification-based targeting, as well as the example that I drew on, which is about prognostic group targeting. And so that evidence base definitely came into our decision-making and thinking about the evidence that we then made it into the papers. I guess my take at the moment on stratifying care based on diagnostic classifications is that we still need better evidence on that. We considered strongly the clinical prediction rule work from the USA, from a series of authors over periods of several decades, matching different treatments to people who seem to respond to those treatments. And we also considered the evidence around the classification-based approach that has been developed and tested both in Australia and I believe in some of the Nordic countries. So that evidence was definitely part of our discussions and part of some of our earlier examples, but it didn't make it in some of the cuts then into the Lancet paper. So I suppose my take on that research is that we need to just be careful a little bit about the messaging, because the evidence base for diagnostic classification and targeting treatment is not yet strong. But again, as I mentioned earlier, I wouldn't stop all research in the space of looking for better approaches to back pain that require a diagnostic model. It would be nice to perhaps take stock internationally and agree what that strategy should be. It appears that we have a bit of a scattergun approach at the moment with different groups testing all different ways of classifying and testing treatments. So getting some international agreement about the most promising way forward, I think, would be good in that space.
Thank you. I think we have time for one more question from the internet.
Yes, a question for Professor Foster. Back pain is a common experience in life. Very rarely has a medical serious condition. So why is it such a problem? There seems to be a spurious correlation between the amount of effort from healthcare institutions and the years lived with disability. Any comments on this? And this is from Edwin de from the Netherlands. Sorry if I pronounced that wrong.
problem. I guess I'd direct that questioner to some of the messages from Rochelle's talk, where she clearly demonstrated why we've generated and contributed to this problem. Back pain is not a serious medical disease, but we have looked at it through that biomedical lens traditionally. And as a result, of course, we have over-medicalized inappropriately a large proportion of patients with back pain. So that has contributed, hasn't it, to the back pain disability. That example that I mentioned in an Aboriginal Australian population that previously didn't believe back pain was a medical health problem, but their interactions with healthcare and imaging changes their beliefs around back pain. A nice example of the negative sequela of healthcare for back pain. So we have to, I think the majority of people in the audience and listening are likely to be healthcare professionals, and we have to, address that moving forward. We have to change the way that we are viewing back pain, and we have to agree with each other about the way forward to try to demedicalize back pain. If it might be, I'm hoping it's still possible to change the way we all think about non-specific back pain.
Thank you so much. I think that is good to have the last words from this session. So now we will close this session.